My second topic will be about Perthes disease, or which is called leg, calve, and Perthes disease. This disease was described in 1910 by different people, different physicians. It is described as a painful disorders of childhood, which characterized by avascular necrosis of the femoral head. Usually, the patient is about 4 to 10 years old, and the boys are affected 4 times as often as girls. Usually, this pathology or this disease lasts for up to 3 to 4 years. The precipitating cause of Perthes disease is unknown, but the cardinal steps in the pathogenesis is the ischemia of the femoral head. Up to the age of 4 months, the femoral head is supplied by metaphyseal vessels that penetrate the growth plate and the lateral epiphyseal vessels that are seen here, which run in the retinacula, and some scanty vessels in the ligamentum teres. The metaphyseal blood supply gradually declines until by the age of 4 years it has virtually disappeared. By the age of 7 years, the vessels in the ligamentum teres have developed. Between the age of 4 to 7 years, the femoral head may depend for its blood supply and venous drainage almost entirely on the lateral epiphyseal vessels, whose situation in the retinaculum makes them susceptible to stretching and to pressure from an effusion. Although such pressure may be insufficient to block the arterial flow, but it can easily cause venous stasis, which results in rise in interosseous pressure and consequent ischemia. The immediate cause of capsular tamponade may be an effusion following trauma, which is the most common cause or predisposing factor, or it may be non-specific synovitis. This pathological process goes through several stages, and in total it lasts up to 3 to 4 years. The first stage is the ischemia and bone death, as we see here in this slide. All or part of bony nucleus of the femoral head is dead. It still looks normal on plain X-ray, but it stops growing and enlarging. The cartilaginous part of the femoral head, because it is nourished by the synovial fluid, it remains viable and becomes thicker than normal. There may be a thickening and edema in the synovial and the capsule. The second stage is the revascularization and repair. Usually within days or weeks of infarction, a number of changes begin to appear. Dead marrow is replaced by granulation tissue, which sometimes calcifies, and the bone is revascularized, and new lamella trabecular fragments are resorbed and replaced by fibrous tissue. When this happens, the alternating areas of sclerosis and fibrosis appear on the X-ray as a fragmentation of the epiphysis. The metaphysis may become hyperemic, and on X-ray it looks rarefied and cystic. In older children and more severe cases, morphological changes may also appear in the acetabulum, not only in the femoral head, but sometimes in the acetabulum also. The stage 3 is the stage of distortion and remodeling. If the repair process is rapid and complete, the bony architecture may be restored before the femoral head loses its shape. If it's tardy and it's slow, the bony epiphysis may collapse and subsequent growth of the femoral head and neck will be distorted. The head becomes oval and flattened like a head of the mushroom and enlarged laterally, while the neck is often short and broad. Slowly, the femoral head is displaced laterally in relation to the acetabulum, and any residual deformity is likely to be permanent at this stage. There are many classification systems of this disease, of Perthes disease. The most widely used is the catarrhal classification that describes this pathology and divided into 4 groups based on the appearance in both anterior, posterior, and lateral X-ray. In group 1, for you, it's for the students of medical college, it's not important to keep in mind the details of this classification. It's useful to know the general idea of this classification only. In group 1, the epiphysis has retained its height, and less than half of the nucleus is sclerotic. In group 2, up to half of the nucleus is sclerotic, and there may be some collapse of the central portion. Group 3, most of nucleus is involved with sclerosis, fragmentation, and collapse of the head. Metaphyseal resorption may be present. In group 4, which is the worst, the whole head is involved and the ossific nucleus is flat and dense, and the metaphyseal resorption is marked. In hearing classifications, which is called lateral pillar classification. Usually it depends on the anterior-posterior X-ray of the femoral head, and we divide the femoral head into 3 pillars, 3 columns. Group A are those with normal height of the lateral pillar. Group B, as we see here. Group B are patients with partial collapse, but still more than 50% of height of the lateral pillar also. In group C, in this case, it shows more severe collapse of the lateral pillar, less than 30% of normal height. Clinically, the patient usually is a boy of 4 to 8 years old. He complains of pain and starts limping. Early on, the joint is irritable and all movements are diminished. But later, most movements are nearly full, except the abduction and the internal rotation. These symptoms continue for weeks and may decrease gradually, and they can recur intermittently and happens again and again in different periods. The patient, this is very important idea, is the patient or the child appears to be well. He does not complain of any general signs and symptoms as fever, chills, other symptoms that refers to other conditions, for example, infective arthritis. And the hip looks deceptively normal, though there may be some little wasting of muscles because of disuse of his extremity. Prognostic factors are usually the age, which is the most important prognostic factor, because the child or the children under the 6 years of age, usually the results are excellent. And after the age of 6 years, the older the child, the less good is the prognosis. And there is a poorer prognosis for girls more than for boys. The female sex has a bad prognosis or a poorer prognosis. And the greater the degree of femoral head involvement, the worse the outcome. We have also the concept of the head at risk radiographic signs, which describes the situation, the risky situation of the femoral head, that we should pay attention to them and we should treat this stage actively. The head at risk signs are progressive uncovering, like here, the progressive uncovering of the epiphysis, and the calcifications in the cartilage lateral to the ossific nucleus and radiolucent area at the lateral edge of the epiphysis, which is called cage sign, and severe metaphyseal reaction, resorption. The treatment, usually the initial treatment of the child with Perthes disease is determined by the severity of symptoms. Analgesia and modification of activities are often sufficient. Symptomatic treatment means pain control, gentle exercises to maintain movements, and regular reassessment. During asymptomatic period, the child is allowed to move and to do, but sports and strenuous activity are avoided. Containment means taking active steps to seat the femoral head congruently and as fully as possible in the acetabular socket, so that it may retain its sphericity and not become displaced laterally during the period of healing and remodeling. This can be achieved either by holding the hips widely abducted in a plaster or removable brace, as we see here, or by operation either varus osteotomy or of the femur or innominate osteotomy of the pelvis, or both, on both sides. And usually the guidelines or the planning will depend on the age and the lateral pillar classifications. So if the patient is under 6 years of age, usually the treatment is symptomatic. But if he is between 6 and 8 years of age, we pay attention to the bone age. If the bone age is below 6 years of age, and the lateral pillar classification is A and B, so the treatment is symptomatic. If it's C, we use braces. But if the bone age is more than 6 years, and we do usually bracing or osteotomy. If it's a type C or lateral pillar classification C, we usually do operation. For more than 9 years old, we usually depends on operative treatment. Thank you for your listening.